Hi, I'm Jack Cush from RoomNow.com, and I'm here in RWCS in Maui with Kevin Winthrop
from Oregon Health Science University in Portland, Oregon, where it's raining, Jack.
You know, it's quite the polar opposite here in Maui. Kevin has given two great lectures here. I thoroughly encourage you to go to the RWCS.com website to look at those lectures on infectious issues pertaining to our patients in rheumatology. But I wanted to ask Kevin a few specific questions that often come up. Kevin, the big issue, the big new development in therapy these days is the JAK inhibitors, you know, and of course, as great as they are, they do come with this other caveat that we haven't really experienced very much of, which is a slightly increased risk of herpes zoster. How much of a risk is it? What should people be doing about it?
Yeah. Well, you hit the nail on the head. There is an increased risk of zoster with these type of drugs. This is first noted in tofacitinib, obviously it was first developed. The increased risk is probably about twofold over the other drugs you guys use. And this has been seen in both clinical trial data as well as real-world data. The risk for baricitinib, at least in the developmental program, looks pretty similar to that which was described for tofa. The other JAKs, we don't know. I think interestingly though, there's this very high signal in Asian subpopulations, which we don't really understand. So the rates are lower in the US, lower in Europe, but much higher in Japanese and other areas of Asia. So that's something we got to sort out. But right now, I think the risk is looking fairly similar between those two drugs. But again, it's early. Time will tell. There's more JAKs in the pipeline. The JAK ones, I mean, we've certainly seen some zoster cases. The rates aren't really well described yet, so I can't really compare them. But I suspect this is a class effect. There might be some differential risk between some of the products, but I think what we're seeing so far is, in general, there's a viral signal in that class of agents.
What's the strategy to reduce risk of zoster in people who are going to put on a JAK?
Yeah, that's a good question. So if you send me a patient, I pretty much routinely try to vaccinate them before they start JAK inhibitor, if I can. So that vaccine, of course, is a live vaccination. So if they're on a biologic presently, it's contraindicated, although you know when you're helping us do a study, we're trying to see if that's safe and effective. But for right now, it's contraindicated. So if they're off those type of therapies, you can certainly vaccinate them before you start a JAK inhibitor.
So what about the VERV study? Tell us what's happening with that now.
Yeah, the VERV study is a study Jeff Curtis and I are doing, along with a number of other investigators. And we are taking patients on TNF blockers and we're actively vaccinating them with the live shingles vaccine, Zostavax. And so far we've vaccinated 150 some people, and there's been no problem so far. I mean, we're blinded, but the DSMB has let us keep going on the study, so I think it's encouraging. And we hope to complete that trial in the next 4 to 5 months.
So people can put patients in that trial by finding out more about it at clinicaltrials.gov.
Absolutely.
Or contacting you or Jeff. We have an issue with our patients who get zoster, and fortunately they're not all over the age of 60.
Right.
So what's your advice when you're talking in the rooms about how to handle those lupus patients or immunosuppressed patients or bad RA patients on multiple drugs who are under age 60, 35 to 60?
Well, clearly the vaccine's labeled for age 50 and above, so you're on pretty firm ground, at that age group. And I think it's been easier to get it approved by payers at that age group the last few years. Below age 50, it might be tough. At least tough to get it paid for. We've done a lot of work, as you know, looking at the risk of zoster and lupus and things. I mean, these people are much higher risk at much younger ages, just like we're young. I think there is a role for vaccination in those folks. I don't know of any formal recommendations that I could cite that push that, but I think clinically it makes sense. I think we've done, and others have done enough work showing the risk is substantially higher in those folks. That if you have a window to vaccinate them, they're not overly immunosuppressed, then I think it's very reasonable clinically to offer that.
So again, live virus vaccination in people on drugs looking for an opportunity to do it, they need to be off drug. My rule that I've developed from the CDC original guidelines was be off for 4, vaccinate, wait 2, and then restart, maybe wait 4. What's your rule, or what's your guidance?
That's exactly my rule. Off for 4, vaccinate, wait 2 to 4. I think probably 4 is better than 2, but it might depend on what you're starting. Whether there's a variety of factors, but I think most of the guidance out there 2 to 4 weeks. I veer towards 4, maybe 3. Let's go 3.
We'll settle in between. You had some great teaching slides. One that caught my eye was when to do PPD, when to do quantiferon, and when to do both. And by quantiferon, I mean any IGRA. You know, there's still people who do PPD. There's still people who have to choose between the two.
Sure.
The IGRAs are kind of dominating. What's your recommendation? Who gets one, who gets both, or who gets which?
Well, I think functionally the IGRAs are much easier to do. Like the patient's there in front of you. You need to screen them for Hep B, Hep C, and TB. You can just do it all at one blood draw, essentially. So I think a lot of people have drifted that way. It's someone who has BCG, they're much more accurate tests. So, I mean, that's not always a concern here. Not a lot of people have BCG histories. But, you know, otherwise, you're right. You could use either test. Now, the CDC guidance for latent TB diagnostics just came out, actually, a couple months ago. And it's published in the Clinical Infectious Disease Journal, as well as the CDC's MNWR. I was really happy because the guidance I've been providing at least is consistent with what they're saying. It's always nice to see that. But they talk about what I was talking about yesterday. I mean, using two tests in people that have risk factors for prior exposure and are high risk to progress. And so certainly patients going on TNF blockers are high risk to progress if they've been infected. I think, you know, the data is pretty clear. You can't trust any of these tests 100%, and there's enough clinical trial experiences where there's, you know, poor overlap between the patients being screened for TB with the TST results, the tuberculous skin test results, and the IGRA results. You get positive on one and not on the other. There's a lot of discordance, and so you know, it's hard to blow off patients with you know, 10, 15 millimeter skin tests despite a negative IGRA. So I think we've all recognized those tests don't identify always the same patients, and we probably ought to use two tests, at least in people immunosuppressed where the tests don't work as well, just to improve our sensitivity.
So is being foreign born from a country that gave BCG, has a lot of TB, and going on and having RA or PSA and going on a biologic enough reason to do two tests?
Sure, you bet. Foreign birth is far and away the biggest risk factor. And I mean, of course, we're not talking about Switzerland, we're talking about other areas of the world where TB is endemic.
I call that TB land, but it seems inappropriate, but it works.
Well, TB land is about 2/3 of the world, so you can look at a map, and that's where it is. So I mean, that's clearly the highest risk factor, the strongest risk factor in the U.S. The other one's really incarceration and a history of homelessness. I mean, those two are probably number 2, number 3 risk factors in the U.S. in terms of who may have been exposed to TB.
Lastly, I want to, you showed a great slide actually showing that TB land overlaps with the worldwide distribution of hepatitis B, which was really kind of cool.
Lands,
and that again brings up another issue that we have. How do you handle the use of biologics in patients who are either hepatitis B surface antigen positive, or those who are B surface antigen negative and have a core antibody that's positive, those who have resolved HBV? What's your guidance?
So I think it's pretty clear if they have a surface antigen, right, they've got active disease. Try not to use biologic. If you have to, certainly get your hepatologist, your ID doc, whoever in your area handles Hep B, get them involved and get that person on an antiviral, and you can probably treat them concomitantly without a problem. There's enough in the literature that attests to that, as you know. You know, if it's a little trickier if they're surface antigen negative. Well, I guess it's less trickier. They don't have active disease, but they're core positive, meaning they've been exposed. They could have cleared their infection, or they could still have it either subclinically. They could have a cold viremia. You just don't know. And so I really think about the surface antibody next, because that tells me what their risk strat is. If they're positive on the surface antibody, they're immune. It's very unlikely they're going to be activated. If they're negative on their surface antibody, which a lot of these folks are, then I worry they may have a cold viremia at baseline. So screen them with HBV DNA to see if they're active. And they're much higher risk to reactivate under conditions of biologic or really any immunosuppressive therapy. So, that's how I think about it. If the surface antibody negative and they've been exposed before, then I really watch them pretty close. So again, that means every 2 or 3 months, that's a Hep B DNA test. If they're surface antibody positive, actually we and others, we write that you should still watch them, but I don't think you need to worry quite so much, that's for sure.
Kevin, great stuff. Be sure to go to rwcs.com, that's r-w-c- the whole thing, to see Kevin's videos and a bunch of more videos that are really quite good. Coming from Maui, thanks a bunch. Watch Room Now.
Thank you, Jack.
Hello, we're coming to you from RWCS 2017. For Room Now, my name is Uma Mahadevan. I'm a gastroenterologist at UCSF, and I'm going to give you a little peek at what I spoke about today. There are several issues of overlap between gastroenterology and rheumatology, and a lot of our patients have similar disease states. There are 4 things that were part of my update. The first is truth about PPIs, or proton pump inhibitors. There's been a lot of press about the negative effect of PPIs. However, we know that they're very important for protecting the gastric lining of patients on NSAIDs and antiplatelet agents. And many of our patients need them, and without them have significant GI bleeds. But are they going to get dementia and renal failure and C. difficile, etc.? So in my talk, we looked at some of the data and showed that for the most part, most of these are very low quality data from big databases that really don't have significant numbers or significant evidence for harm. And if there is harm, you would need to treat a lot of people to have a very small effect. And so, as with any medications, you want to use your PPIs in the appropriate patients and not just keep them on them indefinitely. However, in the appropriate patient, you really should be using these medications. The second disease state we talked about is eosinophilic esophagitis. This is an increasingly recognized problem, and if you have a patient with persistent dysphagia, food getting stuck, despite PPI treatment, you should refer them for an upper endoscopy so that they can be biopsied for eosinophilic esophagitis and get appropriate treatment. The third disease state is celiac disease. If you have a patient with persistent iron deficiency anemia with issues including infertility, ongoing diarrhea, these are patients who you can screen for celiac disease with a simple blood test, and it should always be in your differential diagnosis. And finally, I gave an update on inflammatory bowel disease and some of the new medications that we're using. Many of these medications are familiar to rheumatologists, but we now have shown a very good effect for JAK inhibitors, including tofacitinib for ulcerative colitis, and other JAKs such as filgotinib for Crohn's disease. And these will likely be in our armamentarium very soon, and we're certainly using tofacitinib off-label. Ustekinumab was recently FDA approved for Crohn's disease and has been an excellent addition to our armamentarium. And with that, I thank you for your attention and hope to see you next year.